provide very good rehabilitation for the facilities for rehabilitation. Because of the latest management, the advances in the stroke management, they recover. But then the neuro deficit that continue and the rehabilitation program to manage the neuro deficit is most important in a stroke management. That is the chronic phase of the stroke management, acute phase, the medicine, and also surgery, the intervention. But then following in the recovery, the patient needs a lot of support. The family has to be trained how to support a patient. The patient goes into depression. He'll be, the paralysis continues. He knows that he cannot do a lot of things. The reflexes are, severely affected. So the reflexes to appear, the muscle power to appear, and the person to stand and do the minimum work. This actually requires a lot of rehabilitation program. So the neuro rehabilitation, which includes the physical medicine and rehabilitation department, to be developed and contribute. The psycho rehabilitation, the department of neuropsychiatry to contribute, and of course I'll tell you the yoga, where actually there are few asanas, that are very specific for this bringing the reflexes and also to develop the muscle strength. The muscle specific asanas are also there. So these are the combined effort to be made actually to develop the rehabilitation program for a patient who is recovering from the neuro deficit following stroke. I wish that these are, I'm really so happy that you are really addressing so much, and I'm really excited to see. I am sure I will not be able to attend your entire program, but I'll see the stroke center establishment, because that I also wish that we establish in the neurosciences the stroke, not only a stroke clinic, not only a stroke division, but then as we have discussed rightly, the stroke management center. And I am very keen actually, if I get time, I will definitely come and attend. We will encourage our youngsters to develop a lot of modules of stroke management. With these few words, I congratulate the Department of Neurosurgery under the leadership of Dr. Vikas Jha, and the Department of Neurology under the leadership of Dr. Anand Rai for organizing such a wonderful program. I'll say really a wonderful program. And I convey my best wishes to all of you. I will take leave because I don't have time. So I'll see you again sometime. I'll get back to you.
Thank you so much, sir. Sir, I request Professor Rajkumar sir, Professor Vindya Kumar sir, Professor Anup Kumar sir, Professor Prem Kumar sir, Professor Poonam Madani ma'am, and Professor Vikas Chandra Jha sir to leave the dais and take their respective seats.
अभी एक मिनट
कंप्लीट हो गया।
अरे नहीं है,
अच्छा, वो भी इसी टॉपिक पे है।
टॉपिक हुआ का विद इंट्रोडक्शन और टॉपिक स्टार्ट
Please come on the dais, sir. Dr. Arun Agrawal, sir, ex-Vice Chancellor of Aryabhat University, Patna, And Professor Dr. Sanjay Pandey, sir, Physical Medicine and Rehabilitation, AIIMS, Patna. Dr. Anand Rai Kumar, sir, will facilitate all our chairpersons.
And showing difference of at least 15 ml in hypoperfused brain and infarcted brain. So that those are very different things. So this is a very current topic, and the Chinese trial has been followed with an editorial in same New England Journal of Medicine, which says that well, Chinese have shown this. Does it work in other race? Does it work in other kind of people? So we have to do some more trials to see before we can generalize this to. Perhaps it's time that India also should do. But I'm going to tell you the past. That is very interesting because, and before, I will not take this word because I don't see many neurologists here. This was meant to be a big gathering of neurologists. But just to tell you, what are the advantages of tenecteplase over elteplase? So, one advantage is that its half time is at least 6 times more, which means you can give one IV bolus and that's it. Elteplase you have to go give through infusion, so it goes 1 hour infusion. And so imagine a patient of stroke who comes, you do some imaging, start IV infusion. If you want to do some more tests, you have to carry the bottle, go with the patient all the while. In tenecteplase, give one bolus and good enough. The tenecteplase is 15 times more fibrin specific, which means it will work where there is a clot and perhaps less so in other areas. Therefore, hemorrhages should be less. This is 80 times less prone to be to inhibition by plasminogen activator inhibitor 1, and it has no propagulin effect. So it has some basic biological advantages which we know for years now. In 2018, my resident Telangana is from Telangana. So actually I asked her, why did your father name you Telangana? So I said, no sir, that time my father was fighting for separate Telangana. That is when I was born. So he named me Telangana. What can I do? So Telangana is from Telangana and was my resident. And she presented a seminar which I had moderated and helped her to prepare. It was combining all the studies which are there. I said, this is very good. Why don't you publish it? So she worked with me and we published this meta-analysis. You can see 21st April 2018. So the conclusion is, I can't take you to the details, but the conclusion is that it has similar efficacy and safety as elteplase and maybe superior in one outcome, which is early major neurology. So 21st April 2018,
क्या नाम है आपका?
tenecteplase for MI is approved by USFDA in year 2000.
क्या चलाते हैं?
But for stroke, not
कितना
yet.
सब्सक्राइबर
It has taken
कितना सब्सक्राइबर
24 years.
अच्छा तुम
But they
वीडियो
have
बना
not
रहे
yet
थे
approved tenecteplase. I don't want to
अरे
go
पहले
into the
सिंपल
reason,
कैमरा में बनाओ
but
उसके बाद लोड करना
USFDA, I think
किस
two
पे
of
बनाते
the
हैं?
industry.
नहीं बनाते हैं
So this
नहीं
is
बनाते हैं
why they have
बताएंगे हम लोग
done
मेरा
it.
भी ये ले पकड़िए
Or
मेरा
maybe nobody has even applied. It is cost effective. I don't want to belabor that point, but that is what the notion so far was. That tenecteplase is non-inferior to elteplase as a thrombolytic agent. Within 4.5 hours of acute ischemic stroke, you give this dose 0.25 milligram per kg body weight if there is no contraindication. Contraindications nowadays are restricted only when there is bleeding risk, somebody has been on anticoagulant, somebody had very recent surgery, then only you don't give, otherwise contraindications are very limited now. So evidence is moderate to high quality, much less costly, and it is recommended for use, approved in India, not in US so far. But that is something as an old story. New story is that tenecteplase is probably superior to alteplase, both for bridging as well as primary thrombolysis. And I don't know, it's still so difficult to get your store to purchase tenecteplase, whereas alteplase they are easily getting. But finally, in 2 years' time in RIMS, I got tenecteplase, and we had started thrombolysis almost 2.5 years after I joined. Now, this paper says that this probably is better than alteplase. Again, you won't read the small font, but read this one. In this large study, ischemic stroke treatment with 0.25 mg per kg tenecteplase are associated with lower odds of symptomatic intracellular hemorrhage than treatment with alteplase. So it provides evidence for better safety. This is shown in all kinds of patients, and particularly for symptomatic intracranial hemorrhage. Death which was never shown to be different, is less in tenecteplase as compared to alteplase, at least in this study, and so is the functional independence as well as recovery. In the diagram, you can see how dramatic is the difference in intracranial hemorrhage between alteplase and tenecteplase. So, another paper which came from US healthcare system, I remember it's still not approved by US FDA, but people are using it, publishing it, there is no problem. Tenecteplase versus alteplase before mechanical thrombectomy, experience of US healthcare system undergoing a system-wide transition. They are transitioning to, and what does it say? It says that higher spontaneous recanalization rates with tenecteplase are striking. You can see this. And therefore, probably it will be more efficacious in large vessel occlusion. And that is what they show, 23% recanalization in tenecteplase compared to 10.3% with alteplase. And in this diagram, you can see clearly that 2% had intracerebral hemorrhage. Here, 7.2%. Here, whereas recanalization 10% in alteplase and tenecteplase 23.5%. So gradually, there is a paper now, more evidence it should replace alteplase. So to summarize, tenecteplase may be superior to alteplase in efficacy as well as safety, and probably in wider time window, which I told you yesterday's paper. And bridging with TNK may avert the need for thrombectomy. So if you are doing bridging means, for youngsters, they don't know, you know that there is a large vessel occlusion, you need to remove the clot, but before all these things are done, give this tenecteplase so that in the meantime, we don't lose time and probably the clot gets dissolved and you don't have to do thrombectomy. So that is what one of the extended IA trials showed, that in tenecteplase growth you had much more often recanalization even before you did thrombectomy. So I think now the time is for people, including India, to do a trial 4.5 to 24 hours with tenecteplase, because we are probably different from Chinese. Can't straight away extrapolate from Chinese trial which got published yesterday to our use, but I'm reasonably certain that even, remember, only if you have demonstrated occlusion of M1, M2 or intracranial internal carotid artery and there is salvageable tissue, then you can use tenecteplase. But there is no doubt that even in district hospitals, in all medical colleges, they can use tenecteplase with much more ease and much less cost, and probably more safety than alteplase, and should start using it as widely as possible. It is unfortunate in this part of the country, very few people reach on time. So Still, I'm told that in so many years, only 5 or 6 patients have been thrombolized in RIMS, which is, of course, you know, a lot of problems, education, awareness, transportation, ambulance, so many problems are there, but I hope this will probably increase with time. Thank you very much.
Thank you, sir. I would like to request Dr. A.K. Singh sir to present memento. Professor Dr. Kameshwar Prasad sir.
Can I say something, Dr. Commissioner? Excellent lecture. And what was so interesting at how you have managed to convince others about this point. At the same time, I wonder, what was the point in favor of altiplase, those who are advocating it, what was the point they felt so strongly that they are still fighting over it? You can tell us.
The point they had was that there was more evidence, more data in favor of alteplase as compared to tenecteplase. But that is when I used to say that when you started using alteplase, there was data only on 600 patients. So when you start, you don't necessarily ask for more. How much evidence will convince more depends on circumstances. We are poor people. If we can get something done in 22,000 rupees, why should we waste 60,000 rupees? That is why I thought it is more appropriate that we change even before the rest of the world changes. And we must thank that our country was first to approve in the whole world. So that advantage we had to take, and there was reason why they probably approved it. But it took time. Now I think situation is changed. Certainly AIMS, Rohit will agree, everybody is getting tenecteplase, right? More or less, everybody is getting tenecteplase. It took me some years to get it changed, but it changed.
Yeah, I think wonderful job.
पानी गर्म
Not
है तो
only the
ठंडा
lecture,
ठंडा है तो
possibly
गर्म था अच्छा नहीं लगा
real
तीखा
life.
लग रहा
And any questions and then we can proceed further. Yeah,
Dr. Kameshwar Prasad has been known to me for the past 40 years, and we all missed out on the point
देखो
of
नींद आ रहा है रात में भी नहीं सोए 2 बजे सोए हैं ड्यूटी परसों भी नाइट में किए कल डे में भी किए हैं आज रात में नहीं सोया आज फिर ड्यूटी जाएंगे नींद आ रहा है अच्छा नहीं लग रहा तो फिर नाइट ड्यूटी है तो फिर इधर से जाते हैं क्या बोल रहे थे नाइट ड्यूटी चल रहा था एक लड़की को चेंज करना था न्यूरो सर्जरी में नहीं वहाँ पे प्राइवेट में तो एक लड़की को चेंज करना था ना तो जैसे नाइट ड्यूटी किए थे तो अभी बोले थे नाइट करना तो फिर हमको बुलाना पड़ेगा ना डे आती है तो स्टाफ को देते हैं हम डे में अब सोचिए डबल ड्यूटी हो गई
assistant director.
रात में फोन पे बात कर रहे थे
Sorry for that. And any questions?
नाश्ता भी कुछ नहीं किया आज फ्रूट भी नहीं था कि कुछ खा के आए। उठ के आगे हमको गैस बना रहा है
Sir, what's your personal opinion about use of tenecteplase?
Yeah, can we give them the mic? Sir, what's your personal
मेरे वार्ड वाले
opinion
लोग
regarding use of
मेरे वार्ड
tenecteplase,
वाले लोग हैं
between
वार्ड में
4.5 hours to
न्यूरोलॉजी
24 hours when like interventional radiology is not available, especially in our setting?
2022 में
It will be difficult to justify because you
ये
see,
सर से
most
ये तुम्हारा
important
अच्छा
thing
सर
is
को जानती हो कौन सा
that you should demonstrate a target
मैं
vessel
फेस नहीं देखी
which you are trying to open, right? If
अच्छा
you don't
सुनो बोल रहे हैं
demonstrate,
क्या कि तुम तो यहाँ हो तो ज़्यादा
hence you
आइडिया
do
है
it, but,
तो मेरे को कॉल करना
after
नंबर ले लेते हैं
4.5
मुझे एक
hours,
स्किन
you know
वाले को
that there is
दिखाना है
higher
मतलब
risk of bleeding.
कुछ इन्फेक्शन है
And
खून मुंह में घुसा
surgical
देगी
tissue must be available
तो
for-
वो दिखा मतलब आएंगे तो दिखा दोगे तुम्हारी ड्यूटी
So
कब
these
होता
two
है
things are required.
ड्यूटी
If
तो मैम
it is
शिफ्टिंग
not
ड्यूटी है
there,
ना
then
तो
probably
दिखाना है हमको
not a good
जाएंगे
idea.
प्राइवेट में
So
वो देना
something which
अच्छा
needs to be tested.
आप यहाँ ड्यूटी कर
Beyond
रहे हैं
4.5 hours,
आप
these
यहाँ ड्यूटी
things
कर
are
रहे हैं ना
necessary
नहीं आप यहाँ स्टाफ हो
because you don't know otherwise
ओह
whether you are doing or not.
तो
It is-
थोड़ा हमको
it is a
दिखवा देना
risky
ठीक है
treatment.
अच्छा ठीक
There is,
नंबर ले
even if it is 2%,
वीडियो
there
का
is
पेमेंट है
2%
कितना
85% risk of
50
irreversible
देते
hemorrhage.
हैं।
And once
कितना
hemorrhage
लगा लिया
occurs,
था वो क्या बोलते हैं
50%
कमीशन
will
कितना
go
लिया
down.
था? नहीं
So
हमने
that
लिया
is
था
why we want to
कमीशन।
be sure that
डायरेक्ट
yes,
एग्जाम
there
आया
is
भरी थी।
something
हाँ।
worthwhile to get it.
कौन सा
But
कोर्स कंप्लीट
as
की
I
थी?
told you, before
क्या?
we,
कौन सा
before
कोर्स
our
कंप्लीट की थी?
government approves it,
मैं
we will
बीएससी में
have to
से
have a trial, local trial, or maybe at least two,
कहाँ
three
से?
populations do it.
झारखंड
Then it
रांची।
may be approved beyond foreign. But Chinese trial has,
अब तो लॉकडाउन
Chinese are
अभी
wonderful
तो
actually, they are
यहाँ
beating
वैकेंसी आने वाला है।
US
आया
people
भी
also
वैसे।
right, left and center in
तो
doing
कॉन्ट्रैक्ट
best
वाला है।
trials and publishing in
हाँ
their
नहीं
top
मैम
journal.
अब तो नहीं ले रहे
I
शायद
don't know when
कॉन्ट्रैक्ट में,
India will
क्योंकि
reach
जो पहले
very
से हैं
close.
उन्हीं को मतलब
Thank you so much.
निकालने का ये बात हो रहा है, पता नहीं अब क्या हो रहा है, क्योंकि नॉर्थ से निकल रहा है ना बात ईयरली 2 बार।
Any other question? Okay. Rajkumar Malpura.
Very silly question, because it is required too early once the infarct has already set in. Do you recommend that those investigations related with the bleeding disorders like INR,
आप हमको इनवाइट किया गया है या?
BTT, etc.?
Yes.
हम ऐसे कहीं नहीं जाते,
First thing
इनवाइट
is
हुआ था
that
तभी आए।
don't, if there is delay in getting the report,
किस हॉस्पिटल में
there
वर्किंग
is
है?
no need to wait, right? Unless you suspect that
मेरी मैडम और
patient
सर को इनवाइट किया गया था तो
had
बोले थे
some
वो करने
history
के
of
लिए, फिर उन लोगों ने मुझे
thrombocytopenia
किया
or history of
जो
surgery
व्हाट्सएप से किए
just 2 weeks ago,
भेज करके।
particularly non-compressible sites, or had myocardial
लोग का खुद
infarction,
का
big
वहाँ
ST
क्या
elevation
था,
of myocardial infarction within the last
वहाँ
3
उनका
months,
खुद का
then you hold
सरकारी
on. But otherwise, platelet count, INR, are not necessarily a prerequisite for giving thrombolysis now. So you have to go by history and background, but certainly not be rash. At least you must ask whether patient is on anticoagulant. And if patient is on anticoagulant without INR, you cannot thrombolyze. You are right.
There are many, yes sir,
शेड्यूल
because I
तो
asked
बना
because there
हुआ
are
है,
many
बताने के लिए
disorders which you can see
रोज
them.
खिलाता
Like
पिलाता
for
तो पानी पिला
blood
रहा है।
dysplasias are there, the
11
drug
पानी
users
पिला।
are there, pregnancy, puerperium, different kinds of the disorders which remain almost hidden for all together, for years together. Probably in those cases, don't you think it would be wiser to take the battery of investigations in order to decrease the risk of bleeding, as you have already said that it is 2% vis-a-vis another drug? So
Yeah, yeah.
do you think- yeah.
Ideally,
Yes, yeah.
ideally, if there was point of care test which can be done within 10 minutes, every patient will have it. But the problem is that even in best centers, it takes time. Initially, when TPA was approved, all these things were a requirement. You must have INR, you must have platelet count, you must have, of course, a lot of criteria for exclusion, including previous stroke was, even ischemic stroke was excluded. So a lot of exclusions were there. With time, people are getting more and more experience. And now they think, and there are studies that without INR platelet, but a good history, you will not do more damage. So wasting time is not
11:31.
recommended. But if your lab can provide immediately, nothing like that.
By any chance, does it has any say in reducing the recurrent
वेलकम
ischemia? sir?
एवरेस्ट टॉपिक
Recurrent it won't because it has, as you know, it just lyses the clot,
एपिडोलॉजी एंड
which is there.
टेस्ट
And its duration of action is only few hours. So even lead which is attributed to connectedness or alternate is at the most, we say 24 hours, but at the most 3 days. In trials they took up to 7 days, right? But it won't have action beyond few hours or a day. So beneficial effect will not last, so it won't be very further.
ब्रेकफास्ट यूथ स्नैक्स
So
11:30
it is good
11:30 से
treatment,
11:45
but not prevention. But
न्यूरोलॉजी
after 24 hours of giving this, one can start aspirin or clopidogrel, whatever antiplatelet you want.
I think
we'll leave the stop for the questions and they can discuss at the lunch time.
Thank you.
Now I may request Dr. Devendra Bhushan to talk on stroke neurology, daily stroke, mission and burden in current. Dr. Devendra Bhushan is associate professor in the Department of Emergency Medicine and he is in charge of that department also. He is a junior.
Everyone, good morning to all respected chairpersons and dignitaries and staff and students in the auditorium. So, since long, we as a team, me and Dr. Vikas and neurologist, trying to generate some data from AIIMS Patna and Bihar. And he always speak about what kind of stroke we faces, do we have any data. So, stroke is a significant health concern in India. It is the second most common cause of death worldwide. And what we can see that we exactly don't have data of. In fact, we don't have data of our country. There are patchy data all over the country. There are few meta-analysis or systemic review has been done in various centers like AIIMS New Delhi. Something has happened in the Ludhiana and Trivandrum, West Bengal, and something in the northeast. So, stroke is a significant public health concern in Bihar also. The state has high prevalence of stroke, contributing substantially to overall burden of non-communicable diseases. This is a demographic factor of influencing stroke incidences. So, can we interpolate like this risk factors for the stroke? As the risk factors varies, thus the stroke prevalence increases or decreases. So risk factor for strokes, it is as usual, the strokes are numerous and interlinked, making multi-pronged approach necessary. There are modified risk factors such as hypertension, smoking, and diabetes are the crucial targets for the preventive interventions. Now, trends in stroke and subtypes and its outcome. Understanding the changing landscape of stroke in Bihar requires analysis of subtypes and their outcome. It is seen what we have seen in AIIMS Patna. Almost 80 patients come in a month of a stroke, and what we see that there is a ratio of ischemic versus hemorrhagic stroke. It is 1:2. As we know that nearly 84% are ischemic stroke worldwide. Globally, it is said that ischemic strokes are more. But when we talk about our emergency, in the emergency, there can be various factors. There can be various factors why the hemorrhages are commonly seen in emergency. So they are less ischemic stroke come to you, or it may be interpreted as ischemic stroke is less in our region. So that we have to see. But we have seen that this is our data that there are more hemorrhages, about double the time of ischemic stroke we are encountering. And only 10% patients of these reach in the golden hour of 4.5. So our department is undergoing a project also regarding the thrombolysis in the ischemic stroke, and we are getting less number. We have thrombolized only 15 patients in the last 1 year, and mostly it is with the tenectives. Their cost is a big thing in deciding the agent of thrombolysis. Stroke care and infrastructure in Bihar, there is yes, there is deficiency of many stroke care units, but still the few centers are doing actively work in this area like IGIMS, AIMS Patna. They are doing a little bit of this. So how to establish a dedicated stroke unit? I think this is the topic that Rohit sir is going to tell about us. But it needs not only the instruments or the space, dedication also. So what are the challenges in stroke management? There are several challenges limited access to specialized stroke care, particularly in the rural areas, poses a significant barrier. Inadequate infrastructure, including shortage of neurologists, trained healthcare professionals, and financial constraints too. So how can we improve the stroke care? These menu tasks cannot be done alone. So it needs a teamwork. It needs the involvement of policymakers and the community too. And what about the tele-stroke unit in India? So tele-stroke unit in India are working at many places, especially in the south region. These are the few protocols like Smart India protocol. It is done in the PGI Chandigarh. They took the district hospital. They make the district hospital tele-stroke units, and they start treating them as in the acute stroke management, and they see the significant improvement in the outcome of those patients who were treated by tele-stroke protocols. It is also seen in the AIMS tele-stroke by Dr. Padmanabhan. And there is a ICMR project in the northeast also, where in the area of Tezpur and Dibrugarh, it is seen that almost in that area the stroke is almost 50% is hemorrhagic stroke. And they are doing this trial since 2022 in collaboration with the ICMR. So stroke is a significant public health concern in India with limited access to the timely and effective treatment. And several factors contribute to these challenges, including lack of awareness, inadequate infrastructure, and limited access to specialized healthcare professionals. What we use in the tele-stroke units, tele-stroke utilizes the cutting-edge technology to deliver specialist stroke care to remote areas, bridging the gap in access to timely and effective treatment. And what we need, 24-hour internet services, we need 24-hour CT scan facility, we need a 24-hour dedicated neurophysician or a neurologist or a neurosurgeon. So these things are to be available for a tele-stroke unit. There are many benefits of tele-stroke unit when in India most of the population lives in the rural areas. So to manage those burden, it is very important to use these tele-stroke units. Collaboration of the hospitals, tertiary care center with the primary care centers and CHC is very important in this. Tele-stroke interventions have shown promising results in improving the patient's outcome in India, and studies have indicated a significant reduction in mortality and improving the functional recovery, shorter hospital stays for stroke patients who receive the tele-stroke care. So it has also a opportunity where we can, if those strokes who come late, so in those cases, we as it is discussed, that neuro rehabilitation is a very important aspect. That by this we can enhance the neuro rehabilitation part too. Future outlook and recommendations. Tele-stroke care in India is poised for significant growth and expansion. Expansion of high-speed internet and mobile networks enable wider reach and accessibility. India can learn from best practices in other countries with established tele-stroke network, and continued investment in research and development is crucial to advance tele-stroke technology and improve patient outcomes. So in concluding, Bihar faces significant challenges in addressing the